I'm actually a nurse midwife. I do comprehensive gynecology, and I also do antepartum care. I don't do births at the hospital, but I do postpartum care, lactation support. I have additional training for colposcopy, which is evaluation of women that have abnormal pap smears. I actually also work as a part-time consultant for Planned Parenthood. I do all their colposcopies. I do a lot of IUD insertions, implant-on insertions, and mostly procedure-oriented type intervention for them. I guess I would say that it's the care of women across the lifespan in any specialty, really. Obviously, there's the women's health nursing, there's the educator, there's specialties that focus on childbearing, there's specialties that focus on adolescence, on menopause, on geriatric care, because a lot of times women have very specific risk factors toward each stage of their life. When I went into nursing many years ago, I thought I wanted to work in the emergency room, and I never have. I've never done that. My career has taken me on many different paths, but I've never actually worked in the ER. I've worked in pediatrics, neurosurgery, outpatient surgery, ICU, CCU, and then by chance, when I was in Sumter, South Carolina, the only job opening they had was for a labor and delivery nurse. And there were 6 RNs, and they had a vacant position. So by that time, I only had about a year of nursing experience, and I was put into a night shift position in a community hospital that was very busy to be the charge nurse. And the only way I survived was they had 2 nursing aides who knew a whole lot more about childbirth than I did, and they kept me out of trouble. Thank goodness. And so at night when the unit was slow, I spent time just to stay awake reading Williams Obstetrics. And I basically learned OB by default. But I think because of the tutelage I had and the mentoring I had, I became very good at it. And so it became my career path. Quite honestly, when I started out, before I decided to go to nursing school, I thought I wanted to be a physical therapist. And I guess the biggest message is when you decide, for example, to go to a 4-year program is to keep your options open. Because even though you might be interested in women's health care, or you may not be, you may know that you want to do exercise physiology or nutrition, or maybe not even do 4-year college, maybe start out as a nursing assistant. I guess keep your options open, because when you go to school, you're going to be introduced to so many opportunities that you may not have been aware of. And then you can focus your career path or change your career path basically at any time. Basically, the day starts out with a report, and it's a way to figure out who's in labor, who's not, who's coming in, what you're expecting for the day. You can have women who are coming in to be induced. You can have women coming in for scheduled C-sections, and then you have the unknown, those that are just going to show up in labor or being sent from the physician or nurse midwife's office unexpectedly for the day. You can have women who are term, who you're trying to encourage to go into labor. You can have women who are preterm, who you're trying to stop from going into labor. You can have women who, in labor and delivery, who have delivered, but are so medically unstable that you have to keep them there in the unit so that they can have the nursing one-on-one care, sort of like critical care that they wouldn't be able to receive if they were in a specialty postpartum unit, for example. For an individual nurse, basically you can expect to take care of anywhere from 1 to several laboring patients. The rewards are immense. Even if the pregnancy outcome is not what was hoped for, the feeling of having successfully brought another human into the world never loses its appeal. It's always fun. It's always rewarding, even on the worst day. And that's, I guess, what keeps it very exciting. You're always learning, you're always changing, and that's true in any healthcare field. When I finished nursing school back in 1981, my baccalaureate, I swore I would never go back to school. I'd had it. And I've been back to school 3 times. And it's because, the more you know, the more you want to know. And, I'm never bored. Every day I get to see, 20 women that I consider my friends, and it's a privilege, and I get to visit with them and get a peek into their lives and hopefully have a positive impact for them. And it's just something you just don't grow tired of if you like it. It's very frustrating as a provider to try to help clients, patients, women figure out what their coverage is, what it is not. I teach a lot of young women, just because I see them for contraceptive needs or pregnancy, to try to negotiate the healthcare maze, because everybody, even though it may say you've got such and such an insurance, just like your neighbor, your particular policy can vary night and day. It can vary year to year. It can vary or change every time you change your job. And people don't understand that. They don't know their insurance benefits, and it makes it tricky for me as a provider and a consumer to try to figure out how to manage cost when I don't have all of the information in front of me. It's frustrating where you're trying to manage costs, but you don't get the information until it's after the fact, and then you have to kind of start over. That's probably the biggest challenge I see. Besides the discovery of HIV, I've been in nursing almost 30 years, and that predates HIV. I'm getting on up there. So that was probably the biggest change in healthcare during my career. But the second biggest one I'd say is going to be HPV. I remember learning about the role that HPV plays in cervical cancer, and I was dumbfounded that a virus would cause a cancer. And now we take that knowledge for granted. And now we have the opportunities to vaccinate and help protect future generations. No more do I have patients coming in every 3 to 6 months for repeat pap smears, because we can test for the HPV and target their care more specifically and more cost effectively, and because we have that ability. The changes in contraceptions that have become available, Plan B, for example, to have a contraceptive option after the fact was unheard of 30 years ago. Surveillance for breast health, for example. Now digital mammography is the standard of care, when in the past, when it was first introduced, you had to specifically say digital mammography. It gives the opportunity for the films to be stored on computers, and the images can be lightened or darkened or rotated, decreasing multiple, mammogram exposures on many occasions. Now we're also able to target recommendations and even include MRIs in screening of high-risk populations. With genetic testing, there's lots of focus now on prevention and screening, so that if a family member is diagnosed with, for example, breast or colon or ovarian cancer, we can start to do more genetic testing and then get a better handle on risk for other family members, or reassurance for other family members that it's not a hereditary factor. I think the challenge that I heard from many of the high school students that I taught was that they were intimidated by the cost of education. And my advice would be, if cost is a factor for you, start out small. For example, start out at a community college, decide if that's the career path you want to take, and then you can go to a 4-year college and by transferring. Or if college is out of the picture for you, try to become a CNA. And then once you get a job, many employers will pay for you to finish school or go to school. So I guess that would be my message, is that don't be intimidated by the cost. And I guess the message that someone had told me was that I should not be intimidated by the years of education required. Because like I said, I swore I was never going to go back to school. And if I sat down and added it all up, I've probably been to school 20 to 25 years of my life. But time goes by. And I mean, I wouldn't have done it any other way.